This third and final video will cover some additional unique characteristics of specific antipsychotic drugs in the first generation and second generation classes. In addition, it will provide a summary of the pharmacology of antipsychotic drugs at the end. In general, all first generation antipsychotics have similar efficacy when they are used at equipotent doses. However, there is a very characteristic rank order of potency. From left to right on the screen are the most potent to least potent first generation antipsychotics, with the highest potency being haloperidol and the lowest among the first generation drugs being chlorpromazine. In general, higher potency drugs like haloperidol are associated with a greater risk of dopaminergic side effects like EPSEs and hyperprolactinemia. On the other extreme, the lower potency drugs like chlorpromazine are typically associated with the off-target effects at alpha 1, M1, and H1. Now I will mention a few specifics about each of these first generation drugs. Haloperidol is the most widely used first generation antipsychotic. It has a relatively low risk of QT prolongation compared to some other agents and is non-sedating. It is extensively P450 metabolized by P450 enzymes 1A2, 2D6, and 3A4. Reduced haloperidol is active, which contributes to the half-life of 12 to 36 hours. Flufenazine is medium potency and generally has a balance between the dopamine side effects and the off-target side effects. Flufenazine is one of the drugs that does not prolong the QTC interval. It is primarily metabolized by CYP2D6, and given the polymorphic nature of 2D6, together with the existence of drugs that inhibit or induce 2D6, is subject to many drug-drug interactions. Chlorpromazine is the least potent first-generation drug. It also does not prolong the QT interval. Of the first-generation drugs, it is associated with the most weight gain, and that is primarily due to the presence of stronger off-target effects at the histamine H1 receptor. It is P450 metabolized by CYP3A4 to several active metabolites, which contributes to the half-life of approximately 35 hours. Now for the second generation antipsychotics. Again, as a refresher, the second generation antipsychotics are typically less associated with the dopamine side effects of EPSEs and hyperprolactinemia, whereas they are more commonly associated with the side effect of metabolic syndrome. The 5 second generation antipsychotics I will introduce include risperidone, paliperidone, olanzapine, quetiapine, and clozapine. I will also discuss aripiprazole on the next slide. Risperidone has some of the highest D2 potency of the second generation drugs, and therefore does produce dose-dependent EPSEs and hyperprolactinemia. Risperidone is metabolized by CYP2D6, which makes it subject to polymorphic changes and drug-drug interactions. It does have an active metabolite, which is actually paliperidone, and its half-life is about 24 hours. One other interesting feature of risperidone is that it has an inverted U-shaped dose effect curve, which means that high doses increase side effects with little benefit to antipsychotic activity. So there is a sweet spot in the middle of the dosing range where you get the best therapeutic benefit. Paliperidone is the 9-hydroxy metabolite of risperidone. It also has relatively potent D2 antagonist activity and therefore is associated with some EPSEs, but does actually have one of the highest risks of hyperprolactinemia of any second generation drug. Unlike some of the other antipsychotics, paliperidone is water soluble and undergoes renal elimination. which may be problematic in renal dysfunction. Next is olanzapine. Olanzapine does have a high risk of metabolic syndrome, similar to other second-generation drugs. It also has a dose-dependent risk of extrapyramidal side effects, but again, less so than the first-generation agents. It is metabolized by P450's 1A2 and 3A4 to several active metabolites, and it has one of the longer half-lives of 20 to 70 hours. Quetiapine has only weak D2 activity, and actually one of the lowest D2 affinities of any antipsychotic. Therefore, it has a very low risk of EPSEs. However, it is a relatively potent antihistamine and therefore can be fairly sedating and contribute to additional weight gain. It's metabolized by CYP3A4 to an active metabolite, but even then has a half-life of only about 6 hours. Clozapine is a very effective and efficacious antipsychotic, but due to the potential for significant side effects, is typically reserved as a last-line therapy for individuals who have not responded to other antipsychotic drugs. It is metabolized by P450's 1A2, 3A4, and 2C19, two active metabolites, and has one of the longest half-lives as well at somewhere on the order of 50 to 100 hours. It has significant metabolic side effects, as well as off-target effects at alpha-1, M1, and H1 receptors. It is also associated with a potentially fatal condition known as agranulocytosis. This is when there is an extremely low white blood cell count, as well as a low absolute neutrophil count, or ANC. This does require monitoring for anyone taking clozapine to ensure that blood cell counts remain normal during clozapine therapy. Two other second-generation antipsychotics with very similar activity include aripiprazole and brexpiprazole. These drugs are actually dopamine D2 receptor partial agonists, which means that they can function both as agonists as well as antagonists in the presence of dopamine. That function is indicated by the graph on the screen. You can see the dopamine response stimulated by dopamine, which is a full agonist at the dopamine D2 receptor. In contrast, aripiprazole is a partial agonist and maximally stimulates only about 20 to 30% of dopamine response. However, when you have aripiprazole in the presence of dopamine, you actually get a decrease in the dopamine response because in that context, aripiprazole is serving as an antagonist. However, as a partial agonist, aripiprazole only decreases the dopamine response to its maximal stimulation level, which is about 20 to 30%. This is in contrast to a first-generation antipsychotic like haloperidol, which is a true dopamine antagonist and is able to reduce the dopamine response to 0. This slight baseline level of dopamine stimulation is better able to control the negative symptoms of schizophrenia, given that the negative symptoms are associated with a dopamine deficiency already. And therefore, aripiprazole is generally considered to have more balanced effects on the positive and negative symptoms of schizophrenia. The drug brexpiprazole has similar mechanism of action. Aripiprazole and brexpiprazole both have a low risk of extrapyramidal side effects because they are not fully inhibiting the dopamine receptor. However, dose-dependent akathisia is very common with these agents. They also produce some dopamine agonist-related side effects like nausea and vomiting and orthostatic hypotension, which is unique to these agents compared with any other antipsychotic. Aripiprazole is P450 metabolized by 2D6 and 3A4, and therefore is subject to some drug-drug interactions and polymorphic changes. In addition to being used as an antipsychotic, It is also used as an adjunct to antidepressant therapy. Thus far, we've been primarily talking about oral formulations of antipsychotics, but I did want to mention that several of the antipsychotic drugs are also available in a long-acting injectable formulation. These use various vehicles that can be either water or oil-based to allow for more intermittent dosing and potentially better medication adherence compared to orally dosed antipsychotics. Each long-acting injectable antipsychotic has a different dosing interval, and therefore dosing guidelines need to be consulted for each individual agent. In general, the advantages of the long-acting injectables are improved adherence, decreased relapse of psychosis, less frequent dosing, and overall reduced side effects. However, the disadvantages of the injectables compared to the oral formulations is that they require injections, which can be aversive for some individuals. You also require contact with a healthcare provider on a regular basis, which can sometimes be difficult for individuals who suffer from schizophrenia. One of the most problematic issues with these long-acting injectables is that if there is any severe side effect that does occur, they can persist for several days or even weeks until the dose of the drug has completely left the body. And this can be very problematic for some individuals. Now is our chance to review much of what we've covered related to schizophrenia and the antipsychotics. As a reminder, there are 4 primary dopamine pathways in the brain: mesocortical, mesolimbic, nigrostriatal, and tuberoinfundibular. A dopamine deficit or decrease in the mesocortical pathway is associated with the negative symptoms of schizophrenia, whereas a dopamine excess in the mesolimbic pathway is associated with the positive symptoms of schizophrenia. Although dopamine dysfunction in the nigrostriatal pathway does not typically occur in schizophrenia, when treated with an antipsychotic drug that has strong dopamine D2 antagonist activity, this produces a reduction in dopamine signaling in this pathway that can cause extrapyramidal side effects. In addition, a decrease in dopamine signaling in the tuberoinfundibular pathway by strong D2 antagonists can cause hyperprolactinemia. I said this once and I'll say it again: all effective antipsychotics inhibit dopamine D2 receptors. D2 antagonism improves the positive symptoms of schizophrenia that we typically associate with a psychotic episode, like hallucinations and delusions. However, dopamine antagonism also worsens the negative symptoms of schizophrenia, in addition to causing side effects like extrapyramidal side effects and hyperprolactinemia. Therefore, pure D2 antagonism may not be the best way to go in terms of treatment of psychosis and schizophrenia. Some antipsychotics, and specifically the second generation drugs, also inhibit serotonin 5-HT2A receptors. This is accomplished through a blockade of presynaptic 5-HT2A autoreceptors, which actually increases presynaptic dopamine release in some brain areas, including the mesocortical and nigrostriatal tracts. This activity is able to improve the negative symptoms of schizophrenia, as well as reduce the likelihood of developing EPSEs. Therefore, some balance in the activity of antipsychotic drugs between the dopamine and the serotonin system is likely of greater benefit to patients who suffer from psychosis and schizophrenia. This table from the schizophrenia review article I posted does a really nice job of reviewing the side effects of antipsychotics by class, first generation and second generation. A 0 indicates that that antipsychotic has no effect on that adverse effect or outcome, whereas a plus sign indicates that that antipsychotic may cause that adverse effect or outcome, with a number of plus signs dictating how severe or how strongly the drug produces that effect. Two additional antipsychotic drugs that I have not yet covered are also represented on this slide. These include lurasidone, which is abbreviated LUR, also a second generation antipsychotic, as well as ziprasidone, abbreviated ZIP. Take a moment to review the activity of lurasidone and ziprasidone as second generation antipsychotics in terms of which side effects they are likely to produce. Now is a good time to review the activity of some of the specific antipsychotics we've covered. One way to do this is to create your own version of the table shown on the screen using only the antipsychotics that I've listed as needing to be reviewed for the exam. This will help you delineate which side effects are associated with which antipsychotics and help you further group them between the first and second generation classes. If you need any assistance with working on something like this, feel free to reach me by email or attend the chat to ask questions.